My name is Mike Marchetti. In this webcast, I'll be speaking about lichen planus-like keratosis, or LPLK. LPLK is often a diagnosis of exclusion. Master clinicians describe it as a great imitator, and for this reason, it's not typically included in many dermoscopy algorithms. LPLK is thought to be a host immunological response to an epidermal tumor, most frequently solar lentigo or seborrheic keratosis. We most frequently see LPLK in fair-skinned individuals, 30 years and above, and most commonly in females, and typically occurs on sun-damaged skin. And although the exact trigger is unknown, some have suggested that it might be sun exposure, trauma or friction, or sometimes systemic drugs, like most recently we've seen with checkpoint inhibitor blockade. What does LPLK look like? Well, it can take on many different appearances. They can be pink, violaceous, brown, or gray. Most frequently they're solitary, but they can be multiple. We see them most frequently on the upper trunk, upper extremity, head and neck, and they can be smooth or scaly, flat or raised. How common is LPLK? In this retrospective study of 48,000 biopsies, LPLK accounted for 2% of lesions. They occurred most frequently in females of a mean age of about 60, and 90% were in Caucasians. The majority were submitted with a clinical impression of either basal cell or squamous cell carcinoma, and 90% had focal features of lentigo on histopathology. These authors described two clinical presentations. The first, the so-called classic type, as a pink papule or plaque with epidermal acanthosis and a lichenoid infiltrate, and the second was a hyperpigmented variant that had an atrophic epithelium, scattered lymphocytes, and melanin in the dermis. A study a few years ago examined dermoscopic features of lichen planus-like keratosis. The authors reported that scale and orange color, when it was the predominant feature, suggested LPLK in pink lesions. And among pigmented lesions, if regression was the only feature present, that was suggestive of LPLK. Let's consider a clinical framework of LPLK. I consider LPLK to be of three variants. The first is when you have a seborrheic keratosis, solar lentigo, associated with LPLK. The second is the pink or classic LPLK, and the third is the pigmented or atrophic LPLK. In this first version of LPLK, we tend to see features of seborrheic keratosis or solar lentigo, plus some features of LPLK, like a pink-orange color and scale, or potentially focal gray dots. Let's consider an example. This lady came into my clinic. As you can see on her chest, she has a lot of signs of sun damage, many solar lentigines and seborrheic keratoses, and there was one lesion that on the periphery you could see evidence of a solar lentigo, but we also saw some pink-orange color and some gray dots granules, suggestive of LPLK in association with solar lentigo. 3 months later, you can see that the blue-gray granularity has become even more prominent compared to the baseline visit. And 6 months later, we're beginning to see that the granularity is starting to recede and fade away a little bit, along with the peripheral solar lentigo. 3 years later, the lesion had completely disappeared. Let's examine another example. We see a pigmented lesion on the shoulder. On the right of the lesion on dermoscopy, we see a beautiful example of solar lentigo. At the bottom, we see some early signs of seborrheic keratosis, and we see some blue-gray dots granularity. This is a lichen planus-like keratosis. And a third example, we see focal area of seborrheic keratosis and blue-gray dots granularity with this clumpy appearance, suggestive of LPLK. What about the pink or classic LPLKs? These often have an acute rapid onset of less than 3 months. They occur in a sun-damaged background. They might have scale, scallop, moth-eaten borders, and tend to have a pink-orange tan hue. The vessel appearance can be quite polymorphous with many different presentations. They can even have more of like a accentuation of background vessels, or sometimes more of just a pink structureless blush throughout the lesion. Let's look at some examples. We can see this papule here on the forearm, dermoscopy with this pink, tan, orange hue, a few dotted vessels. Another example here, this pink papule has a little bit of clinical scale, non-specific vessels, a little bit of an orange-pink hue. Third example, pink papule, again, pink tan color, polymorphous vessels, but all of these are lichen planus-like keratosis. The third is the pigmented or the atrophic LPLK variant. We see diffuse gray dots granules, often coarse and clumpy, and the borders are scalloped or moth-eaten. Let's look at an example. In this gray macule on the face, we see blue-gray dots granularity throughout the lesion. It's the only feature present. Here are some more examples of pigmented lesions. All four show clumpy granularity with moth-eaten borders, suggestive of LPLK. And four additional examples. Again, they show this clumpy granularity with moth-eaten borders, suggestive of LPLK. Now we have to be careful evaluating these types of lesions. The first reason we have to be careful when evaluating lesions with regression is that this is an important clue to the diagnosis of melanoma, like in these cases, and it's particularly helpful for identifying melanoma on sun-damaged skin. The second is that occasionally melanoma can present with regression as the only feature, like in this published example. And here's an example that shows clinically a bit of an ugly duckling lesion with this tan gray color. Dermoscopically, all we see is blue-gray granularity and peppering throughout the lesion, but this was melanoma in situ. So my approach to lesions with gray dots granules is as follows. If it's diffuse throughout the entire lesion, clumpy and large granules, and it's the only feature present, most likely it's LPLK. If it's focal, particularly with fine peppering appearance, or there are other features present, then I start to consider melanoma to be the more likely diagnosis. We also have to be cautious when evaluating pink lesions with a differential diagnosis of LPLK, because we know that some of these lesions actually will turn out to be basal cell carcinoma, squamous cell carcinoma, or amelanotic melanoma. Let's consider two examples. Both of these are bright pink lesions. On dermoscopy, both are pink structureless lesions, suggestive of LPLK. But on the left, we have basal cell carcinoma, and on the right, LPLK. Another example showing how difficult it can be to distinguish LPLK from other lesions. On the left, we have a lesion with polymorphous vessels and some slight scale. On the right, again, polymorphous vessels, the fiber signs, some erosions. The lesion on the left turned out to be amelanotic melanoma, 0.8 millimeters in depth. The lesion on the right was LPLK. A final example of two pink lesions. On the left, a pink tan structureless lesion. On the right, a pink purple white structureless lesion with some dotted vessels. Neither of these was LPLK. Both were in fact amelanotic melanoma. So how do I approach lesions that I think might be a pink LPLK? First, I'd like to see a classic clinical story. Acute onset of a pink macule or papule on a sun-exposed site, might be a little bit of scale. On dermoscopy, I look for features of skin cancer. If I see anything that suggests melanoma, basal cell, or squamous cell carcinoma, I would proceed to biopsy. For those that do not have any of those features, I would consider taking a photograph and 1 to 2 month follow-up, or I'd consider a biopsy if that was in the patient's preference. Note that I do not spray these lesions with liquid nitrogen. I've seen several of these inadvertently treated that later turned out to be melanoma. Here's an example of a lesion from my clinic. Patient came in, a lot of solar lentiginous on the chest. She has this pink tan structureless lesion with a bit of scale on the chest. My diagnosis was LPLK. I gave her 2 months of hydrocortisone 1% cream twice a day. She came back for follow-up, and you can see that the lesion has essentially nearly resolved. But here's an example in which I proceeded directly to biopsy. Again, we have a pink papule on the chest, a lot of sun-damaged skin, some other pink lesions. But on dermoscopy, I see some shiny white structures, so I'd rather confirm the diagnosis of LPLK here and rule out melanoma. I hope you found this informative. Thank you for your attention.